Take a letter to the president.
Letter to the president.
Yes, man. Legalize it. Decriminalize it. And I'm on Mr. Banton would advertise it. Sensimila. Me send a letter to the residents of the president with a stamp on the front saying very urgent. The message inside went something like legalize it. Sensimila. Sensimila is a herb that grows naturally, just like any other plant or tree. Natural as the birds, natural as the bees, and just like them, sensi ought to be free to be grown anywhere that we please, in the city, in the town, and in the country, in the hills and in the valley. Sensi should be there for everyone to see. Me send a letter to the residents of the president with a stamp on the front saying very urgent. The message inside went something like legalize it. Sensimila to call sensi a drug is very absurd. It should be known as a natural herb. So much diseases sensi has cured. That's why doctors use it all around the world for glaucoma and fever, rheumatism, arthritis and asthma, insomnia, emphysema, and to block epileptic seizure, to alleviate pain and nausea associated with the AIDS and cancer. Some say it is the best stress reliever. Lord knows I'm a believer. So give me the ganja cookie and the herbal tea. Sensimila is irate. I don't care what no government say. Sensimila is okay. Me ganja cookie and me herbal tea. Sensimila is irate. I don't care what no government say. Sensimila is okay. Yes, man. Legalize it now. Legalize it. Ha ha ha. Legalize it. Let that to the president. Legalize it. Let that to the president. We want legalization, decriminalization, and emancipation for all those sentenced to incarceration for participation with the healing of the nation. It's just another case of political insanity, abusing the rights of humanity. But we should all plant a seed of the sweet that we need to avoid an ecological calamity. We can use it for paper to save some trees, use it for fuel to save some seas, use it for medicine to help fight disease, and use it for food when we're hungry. So give me the ganja cookie and the herbal tea. Sensimila is irate. I don't care what no government say. Sensimila is okay. The ganja cookie and the herbal tea. Sensimila is irate. I don't care what no government say. Sensimila is okay. Me send a letter to the residents of the president with a stamp on the front saying very urgent. The message inside went something like legalize it. Sensimila, legalize it. The way medication, legalize Lord, the way meditation, legalize boy, throughout the nation, legalize it. Yes, with Sensimila. Yes, from Downing Street to DC, time to paint the White House green. You know what I mean? Scene. Let that to the president. Let that to the president. Let that to the president. Let that to the president.
We are going to be starting now the second hour of the conference on medical marijuana. And again, I do want to stress all the hard work that they do at AmericanFreedomRadio.com to make this type of broadcasting possible. We certainly thank them for all they do, and ask that everybody do make it a point to listen to other programs found on this network. With that said, Mary Lynn and Al, I just wanted to like I said, acknowledge the hardworking team here at the network, and I'll hush up and let you get back to this amazing conference.
Yeah, well, I completely agree with you. American Freedom Radio deserves a big bravo. This is a wonderful civil and service that they're providing. Our next guest comes to us from the United States, again, California. We're going to find a lot of doctors out there have been using cannabis with their patients as a medicine for a long time. And one of them is our next guest, a medical doctor named Dr. Jeffrey Hergenrather from, what is it, Sebastopol you're in, Jeff?
Yes, that's right. Sebastopol, California, up in Sonoma County.
Okay, well, well, good morning, and nice to hear your voice again. I think what I'd like you to concentrate on, at least at the beginning, we've talked to Dr. Mechoulam. I know you've heard him and Franjo about the science and the research, etc. How about telling us about you as a clinician? How is that all going, and how does clinical work in California go now? Is it getting easier? Is it getting smarter, or what's going on?
Well, it's going both ways, really. But just first of all, thanks so much for the invitation, and I'm really honored to be with such a esteemed group of scientists and physicians, getting an opportunity to tell my story. I've been in the practice of cannabinoid medicine in Sebastopol with opening an office in 1999, but since we passed the law to allow medical use of cannabis in 1996, I've been making recommendations. I've actually been recommending cannabis to patients since the 70s when I became a physician, because I did appreciate that there were therapeutic uses, but it's come a long way since then. After opening an office and really learning from the patients what conditions cannabis was working for. In order to really develop my scientific basis around my practice, I did join Dr. Todd Mechoulam in the Society of Cannabis Clinicians back in 2000, and along with Fred Gardner, who produces the journal O'Shaughnessy's, to put out information on a regular basis to people, both physicians and patients, in explaining so much about both the science and really the politics of cannabis medicine. And in answering your question, California has a unique law in that we can allow use of cannabis for any condition for which cannabis provides relief. And that opens the door widely. And really, based on our understanding of where these receptors are in the body, it makes perfect sense that it helps with such a wide number of conditions. So I also joined the IACM and Franjo's group in Germany and have been a regular member of the IACM. I've been a member of the ICRS, the International Cannabinoid Research Society, which meets annually between Europe and North America. So going to these conferences has given me a really broad scientific basis and understanding of the science of cannabis and why it works the way it does. Now, in my practice, I really designed the practice to grow slowly because I wasn't really into what I was seeing as these real quick evaluations where you hardly needed more than, be able to fog a mirror to get a recommendation. I just wanted to be able to spend enough time with the patient to really understand their condition, represent them in court if I needed to do that. I usually spend about an hour to an hour and a half with the patient on the initial visit and then see them on a regular basis after that. So I feel very comfortable in my own practice now with about 2,000 patients, probably at least half of them I continue to see on a regular basis. The state has given us a little bit of trouble. They're trying to pass a bill right at this time, which I hope will fail, which is going to put more restrictions on physicians, which probably is actually against the law because the Supreme Court of the United States has protected the physician's freedom of speech right to have this conversation with our patients about the use of cannabis. So limiting the doctor's ability to do that really would be against the law, and I'm hoping new legislation in the California legislature won't pass. I'd like to give you...
Can I interrupt a moment here?
Go ahead.
This is a pet peeve of mine, but this is a special show, and I want to bring up one of my pet peeves. I'm hearing that you, a medical doctor, are having your medical judgment questioned by attorneys and cops. Am I correct?
That is correct. Law enforcement is really trying to get in between the patients and the physicians and determine what they can use it for and how much they can use. In raids in California now, which are really both local and county and state and feds coming into people's homes, they're trying to determine in the raid whether the person's use of cannabis is appropriate and how much they should be able to use. These are not issues that should be determined by law enforcement, obviously.
Well, I agree. That's why I brought the question up, Jeff. And I'd just like to say publicly to the 2 million people that are listening, and I hope that one of them is the head of the American Medical Association, you have abdicated your responsibility as medical doctors to let this happen.
Well,
please go on, Doctor.
Thank you. I wanted to tell you a little about the kinds of patients that I'm seeing in my practice. They range from those who have never used cannabis to those who are very experienced using cannabis. They range from infants to very old people. And I don't think there should be any limitation on the age that people are allowed to use cannabis for medical problems. I have an exciting case with a 1-year-old who presented with his parents with a large brain tumor, and due to a set of circumstances, they decided to try using cannabis oil rather than operate or irradiate or use chemotherapy. And over the course of several months, we saw this large, really inoperable brain tumor shrink, and now after about 1.5 years, disappear. So to put limitations on the age of patients is just way off the mark. This should be determined by the physician. And then I see a huge range, Al, in the kinds of conditions for which patients present for the use of cannabis. And this is obviously based on the widespread pharmacological effects of cannabinoids. Some has been said about the analgesic properties. That's probably the largest single group of conditions, but it's a very potent antispasmodic. It helps with spasms of all kinds, whether it's from stroke or paraplegia, quadriplegia, or whatever the cause. Cannabis stops spasms just in a few moments. It has a potent effect in increasing appetite and stopping nausea. It has many anti-cancer properties. It's antibacterial, antifungal, and antiparasitic. Some has been spoken about the potent anti-inflammatory potential of it, and it works in many inflammatory conditions. It suppresses the immune system, so it's wonderful in autoimmune diseases. It seems to be really helpful for graft versus host, so people that have had kidney transplants or other organ transplants do better when they're using cannabis because it quiets the immune system down. Neuroprotection is a significant role, and people with MS and other degenerative diseases, dementias, seem to have a much slower progression of their disease, if not no progression at all. There are numerous dermatologic advantages in using cannabis for psoriasis and eczema and other lesions that I'll mention in a little bit. It helps the bowel, as Dr. Mechoulam mentioned, in Crohn's disease. It dilates the bronchial tubes, so it helps actually with asthma. It has great qualities in reducing eye pressure for glaucoma. It's anti-diabetic. It helps stimulate bone growth. It has numerous psychological benefits, reducing anxiety, helping with depression, and as was mentioned too, with cannabidiol especially, as antipsychotic. And it's anti-ischemic. It helps protect for heart disease, and it's also an anticonvulsant. So you get the idea that there's this huge range of conditions that really should be treated with cannabis. And in California, we do have that opportunity to use it for all of those various conditions.
Yeah, well, that's good. You know, I was listening to your list there, and I was, after a while, I got thinking of the list that Dr. Mechoulam made up many, many years ago. And your list echoes his after all those years.
Well, yes, it certainly does. And his list echoed the clinicians from the 30s and prior, when cannabis was used before it was outlawed in this country.
Right. Listen, please, again, let folks know the web address, but give us a little on the American Academy of Cannabinoid Medicine, if you would.
The American Association for Cannabinoid Medicine, as well as the Society of Cannabis Clinicians, are organizations that are really one and the same group. We're physicians largely in California, but we're extending out to physicians across the country. We have websites both for the American Academy of Cannabinoid Medicine and the SCC, the Society of Cannabis Clinicians. The Cannabis Clinician website is cannabisclinicians.org. And you'll find some valuable scientific information, and physicians can join in and give us their case reports to help us understand more about the conditions that are successfully treated with cannabis. Which really brings me to the patients themselves, and what I like patients to know when we see them. It really starts with some understanding of the receptor science, and some has been mentioned already about this, but I thought a little more would be helpful, and that is to say that these receptors that we speak of, the cannabinoid receptors in the human body and really throughout the animal kingdom, are based in the nervous system and the immune system. That's where they're housed, and when they're activated by these plant cannabinoids, the THC, the CBD, and the other molecules, they have this wonderful effect of bringing the body back to a home base. When we speak of homeostasis in medicine, we speak of the ability of the body to correct its getting out of line, too anxious, too cold, too whatever. The body has an ability to correct itself. And this is based on the endocannabinoid system. When we activate these receptors, it's like the reset button. It's like restore to factory settings button on a computer. It just brings us back home, helps us to relax. It was Dr. Vincenzo Di Marzo, our colleague in Italy, who said that cannabis and cannabinoids help us to eat, sleep, relax, forget, and protect. And the protection one is about protecting from cancer cells, but also this neuroprotective quality. Forgetting is about the mind's ability to rapidly get rid of unnecessary information that the body is taking in. So there is an important role in forgetting and relearning that is mediated by the endocannabinoid system. I also like people to really have some understanding about risks and benefits of cannabis use. And, briefly, I would just say that the single most significant issue is bronchitis from chronic smoking. We do know from Dr. Tashkin's work at UCLA that it does not cause COPD, emphysema, or cancers of the lungs. Even the heavy smokers do not show any increased incidence of cancer, and in fact really have a reduced risk of developing cancer. So that's something that I like people to understand, although if they are smoking, I often will encourage their use of vaporization or other forms of cannabis because it can be a cleaner way to go and less irritating to the airway. Cannabis, of course, has a habit-forming quality, but it is not addictive. And the NIDA would have us believe that 9 or 10% of anybody who smokes cannabis is going to get addicted, as if this is a big problem. And it's really a silly and misleading designation. So I like people to really understand that, yes, they may use it. It really depends on the condition they have as to how much they use. Some patients are going to use it once a month, and others are going to use it every other hour, depending on the nature of their condition. Any withdrawal syndrome about cannabis use is really quite minimal. A big deal is made of it by NIDA, but it really is a pretty much insignificant problem for everybody that uses cannabis. There's no significant induction of schizophrenia. In Great Britain, when there was an 18-fold increase in the use of cannabis in the youth of that country between the mid-90s and the mid-2000s, there was no increase in psychosis or schizophrenia in that country. I also like people to understand that not all strains of cannabis are the same, and Dr. Abrams has pointed out that there is a difference in the sativa dominant and the indica dominant strains, and there's a difference too in the cannabidiol-rich strains if you want to achieve the medical benefits really without or with very little psychoactivity. So those are some of the things that I particularly like patients to understand on our first visit.
Doctor, you've had 2,000 patients, give or take a few. All of them have used cannabis. What kind of negatives have you seen, if any, besides the minor things you just talked about, et cetera?
I would say over the years there have been 2 or 3 people that have just said it didn't really work for them. They tried it. For whatever reason, they didn't like it. There's a rare person who just really can't tolerate any psychoactive changes. But by and large, people learn a way to use cannabis to mitigate symptoms of their diseases. And it's just been really a wonderful change in my medical practice to specialize in cannabinoid medicine for the tremendous benefit that is realized by patients. And really in California, there are millions of people who are benefiting on a daily basis with the use of cannabis. I think some of the biggest surprises for me in my practice have been seeing the skin conditions and the cancers that have benefited with cannabis use, where we have no other decent explanation for why the tumors have gone away. I've had patients with children with neuroblastoma, adults with melanoma, babies and adults with gliomas and glioblastoma brain tumors, patients with hepatic carcinoma, where these tumors have really melted away with the use of cannabis. They've disappeared with the use of cannabis. These are anecdotes, and we really want to study them in a way that would give much more useful meaning, because I have to say that this, people want to know, is this the magic bullet that we're looking for in cancer treatments? And it is, and it isn't. And in some cases, it really works dramatically to help cancers disappear. And in other cases, it doesn't. And so I want people to understand that when they're going to use cannabis for cancers, that they may or may not find that it really is going to help with reducing the amount of cancer that they've got. It certainly is going to help with appetite and their mood and sleeping and, weight gain and nausea and vomiting and all the other symptoms. But whether or not it'll cause their tumor to disappear or not, some do and some don't.
Worth a try, though, wouldn't you say?
It's worth a try. And as Dr. Abrams said, when patients can grow this in their yard and have this relationship with a living plant, it means so much to them, and it's really worth a try, especially compared to some of the alternatives, which are going to make you sick, if not kill you, in an effort to try to control a cancer. In so many cases, we know that it won't kill the cancer to use conventional chemotherapy. It'll just give you a little more time. But in cannabis, even in some of the most difficult to treat cancers, we do see that people live longer and feel better. So it is worth a try.
Dr. Hergenrather, thank you so much for your time and your knowledge, sir. We appreciate it as always.
Thank you, Al. It's really nice to participate, and I appreciate the opportunity.
Our pleasure, sir. The next guest is Dr. Denis Petro, medical doctor. Dr. Petro has been on the board of directors of Patients at a Time since our inception back in 1995. He is a neurologist with some 30 years experience in adult neurology and pharmaceutical research as well. That research has been done with industry, with regulatory bodies, and he has great expertise in drug safety. He's worked all over the place, U.S., Canada, the United Kingdom, and right now he's talking to us from Eastern Pennsylvania. Hello, Dr. Petro. You out there, sir? Uh-oh.
Dr. Petro?
Dr. Denis, you there?
Hello, this is
okay.
Petro.
So I've just introduced you and told him a little bit about yourself. I mean, that you're a clinician and your experience with patients at a time, but please let us know your background, let the folks about your background, and if you could go back in time and talk about your early clinical findings, especially with MS, and we'll go on from there if you could.
Sure. I actually go back to another era in time, and that is the 1960s. So when I started in medical school at Baylor University in Houston, Texas, in an MD PhD program, I was involved in measuring cardiac output in patients at several of the Houston institutions, including the Texas Institute for Rehabilitation and the Houston VA. And in measuring cardiac output, I was astounded to see that actually a range of patients were using marijuana clinically. Actually, my first patient was a very spastic teenage boy at the Texas Institute for Rehabilitation whose mother would bring in these cookies containing cannabis. And that was the only way I could get good cardiac output measurements after she gave her son some marijuana. And this is actually the same hospital where Gabby Gifford got her rehab after her brain injury recently. But this experience was reinforced in the 70s when I saw a number of patients, one patient especially who had leukemia, and was using cannabis to take chemotherapy, and she became the first recognized adult with acute myelomonocytic leukemia to ever have a successful remission from her leukemia. Another case was a young, late 20s vintage MS patient who actually smoked marijuana in the clinic, and his spasticity literally melted away. So I applied to the FDA to do a clinical trial, and after about 4 years of back and forth, was able to do the first American double-blind placebo-controlled trial that demonstrated that cannabis was an effective therapy for muscle spasms in MS patients. And obviously this study was repeated by researchers in the UK, in Canada, in Germany, and to this day now it is generally recognized that one of the major applications for marijuana is in treating spastic MS patients. But this was sort of a sidelight to my more significant work involving drug development in terms of drugs used in neurology and psychiatry over these years. And in the last perhaps 15 years, I've done much work in terms of investigating the safety of drugs. Obviously, not only cannabis, but drugs used in neurology, such as the antidepressants, antipsychotics, and the therapeutic drugs in general. So that's my background, and I guess that's a good starting point for questions.
I would like to cover the whys of cannabis use with neurological problems. First of all, Doctor, I think we ought to tell the folks that the federal government has a patent, does it not, using cannabis as a neuroprotectant?
Yeah, Julius Axelrod and Hampson and the several other folks in the mid-aughts, that is about maybe 7 or 8 years ago, actually successfully obtained a patent, and the patent is so broad, it really is a joke when you read the patent, but it essentially covers the use of cannabinoids in general, with no real specificity as to which ones, but as neuroprotective and antioxidant agents in treating disorders such as Parkinson's disease, multiple sclerosis, Alzheimer's disease, and other, quote, neurodegenerative conditions. And the obvious error in the patent is it essentially would block any independent person without prior approval, essentially via the government, to use almost any of the cannabinoids in medical research. It is really a ploy by the government, which in essence is a way to block independent researchers in this country. But again, it demonstrates the fact that the government has this technique, which is sort of the emperor's new clothes approach. That is, even though there is a vast array of medical science supporting the indications, and they say that in the patent application, organizations like the DEA, the Department of Justice, and the FDA essentially are in denial about any of the medical literature with regard to cannabis.
Is denial a disease here?
Well, the denial is amazing because, you know, just in the past few days, I saw where one of these medical doctors on CNN had come out and said, well, he had been duped by the government because he sort of believed the fact that there was no good research about cannabis, and now he's touting the fact that, yes, in fact, marijuana is an effective treatment for diseases, yet, he's really come late to the party because it's generally accepted that cannabis has many, many uses, and certainly, you know, the way the drug development process works, it's not the fact that cannabis can be used in pain syndromes or in spasticity or in nausea of cancer chemotherapy or in post-traumatic stress disorder, etc. The very fact is that we are blocked in the ability to investigate scientifically in the United States. That's why it's now being revealed more and more when people like Dr. Gupta come out and say, well, in fact, marijuana is an effective drug and is in fact that is in distinction to the government's approach.
Yeah. Could you tell folks about ALS, seizure problems, spinal cord injuries, Parkinson's, Alzheimer's? Those are neurological problems. Does cannabis work for these problems in everybody, in most people? Do we know?
Well, I'm glad that you've given me the next 2 hours so I can go into detail about each of those problems. I'll start with spasticity. There is obviously a full range of data that demonstrates that cannabis has an anti-spasticity effect. Of the maybe 400,000 MS patients in the United States, spasticity is a major problem in perhaps 80% of that group of patients. And there is no doubt that cannabis is effective. Now, there is a small minority of patients that have a syndrome which is not that is not represented primarily with spasticity, but with other physical signs. And those patients may, in fact, not get relief because they don't have the symptom for which cannabis is effective. So there may be a small, maybe 10 to 20% of the patients with MS who will not get benefit, but that's because they don't have significant spasticity. In ALS, the evidence is clear that for certain symptoms associated with the ALS process, and that includes things like excessive secretions or excessive oral secretions, and in terms of appetite issues and in terms of sleep issues, these things that some non-physicians may say are really not important, well, to an ALS patient, they may be absolutely critical. And cannabis is clearly a benefit in those symptoms. And, although, if you say, well, has there been a clinical trial in ALS? Again, that goes back to the fact that it's very, very difficult to do the clinical trials. So it's mostly observational, but it does support the use in ALS. The second part of that is, in terms of ALS's being a, quote, untreatable disease, remember that the government's patent says that, again, cannabis has antioxidant and neuroprotective properties. And one might suggest then that it might be a reasonable drug to slow the progression of the disease, but that has not been studied in any great depth. In seizure disorders, there may be 30 or 40 different diagnostic types, so I won't go through all of them other than to say that certainly there are many, many patients with seizure disorders who have been shown to either decrease the frequency of their seizures or, in fact, stop them pretty much totally. And again, the mechanism of action of cannabis on the nervous system would be supportive of an anti-seizure effect. But if you're looking for clinical trial data, there isn't a whole lot to hang your hat on. Now, in terms of Parkinson's disease, there are two approaches. Number one is going back to that government patent. Remember, they say, gee, the cannabinoids may be beneficial in Parkinson's disease as far as the neuroprotective aspect of the drugs. The second part of it is in patients who are initiated on the usual dopaminergic therapies, the drugs like Sinemet or L-Dopa, they wear off over time, and there are many patients who claim that when they use marijuana, it tends to smooth out the on-off effects of their Parkinson's syndrome. So, finally, in Alzheimer's disease, going back to the neuroprotective aspects of cannabis, it may be a drug which slows the progression of this awful neurologic disease, but we don't have definitive data to say one way or another. But it certainly would be a treatment option in patients who are concerned about trying to limit the progression of that disease. So in terms of seizure disorders, Parkinson's disease, motor neuron disease, and MS, there's a multitude of publications which would support, both in animal models and certainly in spasticity in human studies, that the drug would be beneficial.
Right. Before we leave you, Doctor, I wonder if you could just give the folks a couple of examples of people with MS and ALS that you and I both know closely. I'm thinking here of Barbara Douglas and Kathy Jordan, who are both known to you. Could you tell the folks their experiences with cannabis?
Sure. In both patients, what we're dealing with, just to give you the Kathy Jordan story, by all rights, she should have died 20 years ago if you believe the natural course of a disease, which, incidentally, she's been followed by several of the world's important thought leaders in terms of the disease, and she carries with her a letter, or at least a little note supporting her cannabis use by one of the gurus relating to ALS. In MS, now, there have been questions with regard to the whole range of drug therapies because they have a treatment benefit effect, but it really isn't particularly significant when you think in terms of the progression of the disease. I'll give you an example. When we look at the normal MS patient, we can predict in looking at a population that in 10 to 20 years they will be in a wheelchair, and certainly their life expectancy will be decreased by 8 to 10 years on average. Now, when you look at patients, and the patients you mentioned, for example, their survivorship is testimony to the two things. Number one is they certainly aren't progressing more rapidly than the predicted course. And in a case like Kathy Jordan, by all rights, she should have died 10, 15 years ago if you look at the normal path of progression of this disease we call Lou Gehrig's disease, or ALS.
Thank you, Dr. Petro. Again, you've always been there for patients at a time, and you were again today, and very much appreciate it. I'll talk to you soon.
Righto. Bye-bye.
And before I introduce my co-host here, really, I'd like to just read a very quick statement from a member of Patients at a Time Board of Directors who was scheduled to speak, but he's a resident and he's a clinician and he's out there doing his job as we're on the radio. His name is Sunil Agarwal. He's a medical doctor and a PhD, and he's a senior resident physician right now in physical medicine in New York City at a big hospital there. He's also a member of the ASA Foundation board, and he's a palliative medicine fellow at the National Institutes of Health Clinical Center. He's very much interested in cannabis, of course, and he's very much interested in taking care of patients. And here's his little statement that I'm going to read from him. That adequate and well-controlled studies proving the medical efficacy of cannabis exist, that are ignored by marijuana schedulers in the Department of Health and Human Services, under which the FDA resides. Large, multi-center, randomized, double-blind, placebo-controlled studies involving hundreds of patients in America and abroad that are some cases a year in duration have been published in the United States National Library of Medicine index journals, showing that marijuana, orally administered in extract form, can treat intractable pain and cancer and improve mobility and symptom control in multiple sclerosis. Moreover, cannabis marijuana, plant material, is one of the best studied and characterized plant materials in science. As of 2008, there were over 15,000 articles alone on the chemistry and pharmacology of cannabis. In my own research with prospective survey-based and retrospective chart reviews of 176 medical cannabis patients, I have found that medical cannabis can be used to treat a wide range of chronic pain syndromes, manage other symptoms, and maintain and improve health-related quality of life. The distress patients experience due to their criminalized status under federal law or local regulations is a violation of their human right to health, care reform, and quality improvement. Please check out my work at www.cannabinoid.com. Thank you very much, Dr. Sunil Agarwal. Now, the final guest was my co-host, but we changed it to make me the moderator, but my co-host is Lynn Mathre, and she is the next presenter. She is a registered nurse and addiction specialist. She is my wife. She is the president of Patients at a Time and the president of the American Cannabis Nurses Association. And her job today here is to finish up this conversation, explaining why the nursing community, as well as the doctors and other healthcare professionals, are so important to patient care and the care of cannabis itself.
And hello, everyone, to the American Freedom Radio listeners out there. We really appreciate Casper Leitch arranging for this show. And what we wanted to do was bring you some scientists and clinicians to talk about medical cannabis And my job, as I said, we want to bring in the nursing perspective as well, since nurses do spend the most time with patients. In the United States, we tend to be voted year after year as the most trusted profession because we do see patients at their weakest time. And back in 2003, the American Nurses Association passed a resolution in support of cannabis, and since then they have issued a position paper in reaffirming that in 2008, and they will be revisiting it again every 5 years, and they certainly feel that they haven't changed their position. So I do want all nurses out there to know that, you know, as a whole, our American Nurses Association does support cannabis as medicine, and that is a really, really important place to go to. Why is cannabis, you know, let me back up. My practice has been in hospital settings in the early years, first as a Navy nurse, and then later in hospitals as a medical surgical nurse. One of the most stressful jobs we have, and different hospitals do it different ways, but many times you might have a nurse being the medication nurse, or in other areas, the nurses just take care of all of the medications just for the patients they're assigned to. Either way, you're spending your shift making sure the patients get the right medication in the right dose, in the right route of administration at the right time. And it's very stressful. Finding out, you know, sometimes you don't know these patients very well, and you might have 20, you could have 50 patients. In the military, I had quite high numbers of patients at a time, and you're trying to get them all this right medication and hope you don't make a mistake because of what could happen should you make a mistake. Now let's introduce cannabis as a medication to the hospital. I've looked at, and other nurses that I talk with who are familiar with the use of cannabis, we kind of look at it as nurses as a great tool in nursing care. The medication is safe. We're not going to overdose anyone. We're not going to kill anyone. We're not going to destroy their kidneys or their liver. We're not, all of these things that can happen with the wrong medication to a patient. So right away, there's that little safety factor. But as you've heard before from some of the other clinicians, Dr. Abrams, Dr. Hergenrather, there's different routes of administration. Patients don't have to smoke. They can vaporize. One of the guests we've had before, Michelle Aldrich, was able to actually use a vapor pen in California while she was undergoing treatment for lung cancer. And the nursing staff there were very welcoming of that. It had no problems with her, with other patients in the area. No one else was going to get that medication. It was in a dose that she could handle, and provided relief almost immediately. I think the other thing that for nurses, when we're giving medications, a lot of these medications that we do give have the side effects that are difficult to deal with. You treat someone for pain, they end up over-sedated. You might treat someone for something else, and the medication causes them to be extremely nauseated and they're vomiting, or they just lost their appetite because of the medications. So cannabis not only helps with many of the symptoms that patients complain of because of their diseases, but literally helps with a lot of the symptoms of the side effects of the standard medications that they're given. And in that respect, again, trying to use cannabis, the nursing time, I look at it and think how much time I could save if I was giving cannabis to several patients. Again, whatever form is appropriate for the patient, whatever the route, whatever the frequency. But to give them that, and I would probably could save, and I would say easily 50% of my time. And that's not saying that we get rid of all the other standard medications. There certainly is room for that. But I think the point that I would like to make from a nursing perspective is that this should be one that physicians should have the freedom to use their clinical judgment and recommend it possibly as the first choice because it is so safe. If it doesn't work, maybe they need to try other medications and something else. But why start with a powerful drug with potentially harmful side effects when the patient could try something that generally literally makes them feel better all the time. I think, again, our speakers have talked about trying to make different points, and the other point about cannabis is it's not all about the THC. THC has its therapeutic effects, but it also is the primary psychoactive cannabinoid in the plant. And that's why you've heard them talk about CBD, cannabidiol, non-psychoactive. When taken with a cannabis, when in the cannabis plant with THC, it helps actually lower the high effect. So when we're talking about medical cannabis, we're not talking about super stoner pot to get someone really high. We're talking about delivering medicine, whether it be by a vapor pan, vaporization in some sort of manner, and that's meaning that we're heating the material so that the effective medicine is released and people can inhale it, but it's not hot enough to where it burns, so they're not inhaling smoke. That's a wonderful delivery. But there are salves made for patients, whether it be skin conditions, psoriasis, arthritis, rubbing it onto their joints, using it for skin cancers. The oral, very concentrated oils or tinctures people can take, and they literally dissolve in the mouth, so they get into the bloodstream fairly quickly. All of these things can happen and are happening in places that allow cannabis, but the other states, again, I think the population only thinks of cannabis as smoking marijuana and getting high. I think one of the big problems we've seen with patients is non-compliance. It happens throughout. It's always a discussion in hospitals. How can we help with compliance? And I think the first thing that any good clinician knows is the way to get compliance with a patient is to make sure that they're included with their plan of care and that they actually agree with the plan of care, rather than just being prescribed something and told, here, I want you to take it, and they don't pay attention to how much this is going to cost the patient, how it's going to interfere with their life, if they can remember to take the doses on different times, etc. Or the fact that they just might not like some of the side effects, and the patients quit taking it on their own because it never really helped them that much. Again, cannabis, I think as Jeffrey Hergenrather had said, and others, that they've learned from their patients. Patients often are coming to healthcare professionals saying, this really helped with my spasticity. This really helped with my seizures. I'm having fewer. Whatever it is, they're coming with information. They've discovered this on their own, and they do want to learn more. They want to know, is there a better strain for me to use? Is there a better form for me to take it? This is very important for healthcare professionals to take on. And when we ignore it or just run the other way because of the fact that it remains illegal in the United States and many other countries, as Franjo Grotenhermen alluded to, that's not serving the patient. It really is up to healthcare professionals to stand up for our patients and advocate for them. I did want to comment a little bit about the gateway drug effect. And again, I'm so glad this was brought up a little bit about addiction. Yeah, overall, they say that the old standard statement has been it's a gateway drug. You try marijuana, and the next thing you know, your kid's going to be on heroin. That has been shown. It's not a property of the drug. The Institute of Medicine, when they did their report, what they found is it's not a gateway drug, but perhaps the fact that it's illegal and people go to the illicit trade to find their drug, and if they're out of cannabis or something, the drug pusher is going to push something else for them. Here, I've got something, this will work right now, or this is cheaper, whatever it may be. It puts them into that category of already breaking the law, and that's the bigger danger here. So when we look at it in the addiction standpoint, I have been an addictions nurse since 1985, certified in addictions nursing. And I ran a program. I was the charge nurse at a treatment program at the University of Virginia. And the whole time I was there, we did have one patient come in with marijuana dependence, a young person. He just seemed to, all he could do was, smoke pot all day. We helped him. But I believe for the most part, that's not what we see. We never see it. We do see a lot of people with addiction problems who do use cannabis. They find it helpful when they run out of their drug, if they're having withdrawal. And it's there if they need something else. It sometimes quiets down the negative effects from the other drugs. But in places such as Vancouver, with Philip Lucas has done some research, and at the Berkeley Patients Group in Berkeley, California, Amanda Ryman has done some research. They're looking at their patients, surveying their patients, and they found many patients who've had problems with alcoholism, with heroin addiction, with other opioid addiction, with cocaine problems, methamphetamine, tobacco, have found that cannabis is the drug, the medication that actually helps them get off those medications. So it's been kind of termed an exit drug, and I think that is much more fitting than the fact that it's in Schedule 1, which means it's a highly addictive drug. That in itself is just not true. And you could ask any clinician, any place, we would never be admitting a patient to a hospital for marijuana or cannabis withdrawal. It's just not that severe. I think the other thing that's a problem with that scenario about the withdrawal, some of the withdrawal symptoms may actually be a condition that a patient had prior to even using cannabis, whether it be depression, and the cannabis helped with that depression. Well, you take away their medicine, and they go back to being depressed. So sometimes, again, we need much more research on this to learn what we want to about it. Well, I think if I go any further, one of the other things I want to point out is the
Mary Lynn,
not only medicinal value of cannabis, but
we're down in the last minute, Mary Lynn. Go ahead and wrap it up.
Okay, last minute in a quick sentence is for, I encourage everyone to go, they heard a little bit with hemp, but look at the nutritional value of the hemp seed oil, etc. There's new research on cannabis. I did want to tell people the American Cannabis Nurses Association, that's who I wanted to represent today. We're a new organization. Nurses really believe in this medicine. You can find us at cannabisnurse.org or AmericanCannabisNursesAssociation.com.
And for Patients at a Time, thanks so much to American Freedom Radio and all our guests, and to you as well. So.
Yes, and I want to thank you so much for bringing your amazing group of people to this presentation and to inform our audience and the leaders of the world of the need to end prohibition. Next Friday, Michael Krawitz from the Veterans of Marijuana Access, and Jeffrey Dyewood, who wrote the book World War D, will be the moderators of panelists, including Judge James Gray and Ben Drunkers, and a great list of other stellar people from around the world. This conference has been put together on behalf of Time for Hemp, and we want to say thank you to AmericanFreedomRadio.com for making it possible. And remember, the next time you hear me, you'll know that it's Time for Hemp.
Don't cut trees for paper, 'cause it hurts the environment. Stop deforestation, yes, it's time for hemp. Whoa, an acre of hemp makes 20 barrels of oil. No need for pesticides to poison